My name is Naden Kreitz. I'm a third-year medical student at the University of South Alabama. And today we're going to be talking about, drop it like it's hot, long-term hormonal blockade for high-risk endometrial stromal sarcoma. So endometrial stromal sarcoma finds its place in this ever-changing uterine corpus tumor classification. So you can see here, WHO classifies it as the tumors of the uterine corpus, breaks it up into three: mesenchymal tumors, endometrial epithelial tumors, then mixed epithelial mesenchymal. And then mesenchymal is further broken down into endometrial stromal, smooth muscle, then miscellaneous. And endometrial stromal is then broken down to endometrial stromal nodule, low grade, endometrial stromal sarcoma, high grade, and then undifferentiated uterine sarcoma. Specifically, endometrial stromal sarcoma, it's a very rare malignant tumor. It comprises approximately 1% of gynecological malignancies and less than 10% of uterine malignancies. Typical presentation is it's going to be just a normal uterine bleeding, pelvic pressure, an enlarged uterus, and abdominal distension. And the standard treatment currently is a hysterectomy plus a BSO, and there's no current consensus on hormonal adjuvant therapy. And so this, the case presentation was a 22-year-old female, G0, with no past medical history, presented to an outside ED with worsening lower pelvic pain. And so because of that, they suspected maybe ovarian torsion. It was a rural hospital, so she underwent a robotic-assisted laparoscopy with uterine biopsies and hysteroscopy. The uterus was noted to be enlarged, and a solid cystic mass was found in size and biopsied. The endometrium appeared normal and curettage was benign. The MRI revealed an 8.8 by 8.3 centimeter mass in the pelvis, an intrauterine abnormality with a 4 millimeter capsule with multiple thin septations and bladder distension. She was then transferred to our institution for further evaluation by gynecology, oncology team members. And then she was discharged. Pathology resulted as ESM versus low-grade endometrial stromal sarcoma with the following characteristics: CD10 positive, estrogen and progesterone receptor positive, SMA negative, and no mitosis/necrosis. So then she underwent an exploratory laparotomy with resection of the mass. And during that procedure, the mass was described as fleshy and soft, mostly avascular with necrotic yellow tan discoloration with what appeared to be adipose tissue versus thecal tissue within it. And then after that, the patient was then counseled on her treatment options of a hysterectomy versus a wedge resection of the myometrium. She chose the wedge resection for hopes of trying to keep fertility the best as she could. And then pathology after that confirmed clusters of atypical endometrial stroma in the myometrium with focal lymphovascular invasion. So this concluded that it was a low-grade endometrial stromal sarcoma. And so after that, it was then recommended to her that she goes a total laparoscopic hysterectomy. So final pathology after the hysterectomy reported with persistent low-grade endometrial stromal sarcoma with an 8 millimeter invasion into the myometrium, with lymphovascular invasion in addition to negative margins, negative biopsies, and other signs of cancer metastasis. And so then after the procedure, she was put on Lupron and HG-ESS hormonal blockage every 3 months for 2 years. And the patient now has been disease-free for the past 2 years. And so there is no consensus on whether adjuvant hormonal therapy is, required or needed. There's very small data out there. There's just case reports and very small retrospective small population studies, but it has been shown to decrease disease recurrence following the treatment. So yeah, and that is it.
All right, so do we have any questions?
I know you said that there's usually not a role for hormonal medications in endometrial stromal sarcoma, but I noticed that you said that her particular tumor was ER/PR positive. Is that atypical for an endometrial stromal sarcoma?
I saw that from the literature, the low grade it's not, I wouldn't say it's atypical. I think I think since she was ER/PR positive, the hormonal therapy was even more of a go-to for her treatment. But I can't answer if that's like truly atypical all the time. But because she was ER/PR positive, hormonal therapy was considered, and it's been working. So
Thanks.
How common is it that wedge resection ultimately ends up having to transition to a hysterectomy or total?
That is a great question. I do not know. We'll have to look that up.
Okay, well, thank you so much.
Thank you.